Thank you all coming here to listen to me sharing my experience with the low back pain management area of very great interest always. And I guess for many of you who are here, um, my focus is going to be very much onto the use of technology in back pain management. Now, probably this is in contrary to what is happening around the world, and whereby people are trying to shy away from the technology and try to go more into hands-on approach. There's nothing right. There's nothing wrong. We need to make the best fit. What is the best for the patient? So let me share with you what is our evolving role in terms of managing back pain. We have been practicing these techniques for several years. Our clinic has been running here in Singapore for 15 years, and we practice these specialized techniques in our center with amazing success rates. And over the year, what we developed is the evolution of this concept. We call it as SCORES Back Care Program. So the word SCORES basically stems from S standing for spine. Core is working on the core development, which is primary importance in terms of chronic pain management. So we are trying to put all the available research and recent technologies together so that we can create the best outcome for the clients. Now, if you look at a very classical model, which was devised by Dr. Manohar Punjabi, 1992 is kind of a gold standard model that talks about the lumbar pain and the lumbar stability. He classically defined the spinal model to be governed by three key subsystems. Okay. One is your passive support system. So if you look at your spinal column here, your spinal column is your passive support system. Then you have active support system, active subsystem, which is your muscles. So muscles create the dynamic movement on the spine. So that is also very important component. And third is the neural input or neural control subsystem. So these three subsystems, which consist of your spine. Are you able to see my spine model?
Yes, sir.
Okay,
able to
see. Good. Okay, so you have this passive system, and on top you have the muscles, which is active, and then you have your nerves also, say spinal cord and the nerves which are passing through. These three work hand in hand to create the stability and normal biomechanics of the spine functioning. Now, when you are treating a back patient, you really have to understand the role and impact of each of these components, and that's important. So if the spine is stable, there's very little movement, as you can see. But if the spine becomes unstable, so if I loosen it up, and you see how the spine is able to move so easily, and this will create this stability and resulting in the herniation of the disc, one of the leading cause of back pain. So what is very important for every clinician to understand that there is no one sure short method of treating back pain. Most important for us is to really do a proper, thorough assessment and evaluation of the spine, and then make your conclusive direction of management. So if we look at this, if we look at causes of the back pain, they will be primarily originating from any of these three or combination of these three aspects. One will be your facet joints or bone-related pathologies. Second will be your muscle-related pathologies such as muscular strain, sprain, and so on. And the third will be your nerve-related pathologies, right? So you need to understand where the pain is coming from. So very classically, if you see somebody who's got a sciatica involvement, shooting, burning, throbbing, pain radiations, obviously it is indicative of nerve-related pain. And what is causing that? So you need to understand. So if it's a disc herniation, then you have to address your management strategies in the right manner that address the resolution of disc herniation. So back pain, if we look at there three, the active support system failure. The active support system failure, we can manage it via getting the patient into core stability training program. Now, in our experience, what we are doing is we are actually using imaging ultrasound, diagnostic imaging ultrasound, whereby we are able to visualize the patient, what muscles they are supposed to be contracting, and in relation to the other muscles. So it's a very, very structured and very focused training that aims to strengthen not all the muscles, but only the weak muscles. Because it is not all the muscles they undergo weakness. The imbalance in the spine happens because there are certain muscles. The core muscles are your stability blocks, stability pillars around the spine. So your core muscles are your pillars around the spine, which is holding it stable. So you need to address them correctly. Any structural support failure, which is example, the disc herniation and so on, is addressed through the spinal decompression technique, right? So my focus today is going to be more on spinal decompression technique that I'm going to share today in terms of technology due to the limitation of time. And secondly, the availability of these resources for you to practice in India. I know the traction is something that has been commonly practiced in India, whereby we are facing a bit of challenge to introduce technologies like imaging ultrasound for exercise training because of certain regulatory restrictions, that does not make the technology accessible so easily. So everybody is very familiar about traction, nothing new, but some people believe in it, some don't believe in it. Sometimes you get result out of it, sometimes you get adverse result out of it. And unfortunately, as I'm watching what is the trend happening, there has been a little bit shift away from applying the traction forces to the spine. And that is primarily happening in the European sector. And it's been getting caught up in other areas also. And no offenses to any of such development, but what is important is, I feel, is the lack of understanding using mechanical forces to the spine. And that does not give users enough confidence. We have used the mechanical forces to the spine to the best of our understanding with the amazing number of patients in last 15 years with great results. So traction is a direct. Traction, if you look at it, it's a direct modality. It's not an adjunct. So if you're using techniques or technologies like TENS machines or interferential current, or you're using laser, yes, they will be working on the tissues, but they will not be able to work to create any type of decompressive effect. Other modalities are working as an adjunct. They're working on process of inflammation, healing. Traction is a force that is applied to the spine that is creating desired result through the positioning of the patient. That's very important. So what is critical is how we apply the force to the spine. Now, there's a growing buzz going on now is about spinal decompression systems. I'm going to share with you how these have been developed over years, because I have been very actively engaged in this whole process of development of these technologies. So traction, and in the later year, there's a lot of spinal decompression also coming in. What is decompression? Decompression is basically separation of spinal segment in y-axis at the targeted area, right? So if we look at the spine here, and which is actually, this is the disc, you can see the disc, and which is in a compressed state. So our objective is, when you have disc that is being compromised and compressed, we need to do axial force execution. There's nothing better going to work to decompress a disc unless we apply the axial force in this direction that allows the greater space between the disc, two discs, and give a kind of suctioning effect to the herniated disc to retrieve and revert back. Now, effective decompression has to be done in a manner that we are able to separate the spinal segment to about 3 millimeter, and that is very important. Okay. And here, if we look at what are the techniques commonly practiced, now many people are doing manual therapies, right? So if you look at these pictures, what are we doing here? We are basically providing a traction force. We are providing a traction force. Now, if such traction force, which is applied in the axial direction, works great in the cervical region, why not in lumbar region? We can't do it, unfortunately. Manual axial force with ease in lumbar region, because the sheer weight and volume of the patient is very difficult to do it. The only way to go is to go the mechanical ways. So if we look at different traction options, so these are, as you probably have been practicing in your clinicals, having the patient positioned, have the flexion stool, apply the force, and try to stretch them. Now, if your tables are not of right quality, that are able to move back and forth, create less friction, your force may be lost in the overcoming of friction. Now, some people even go into inversion traction tables like this, whereby using effect of gravity to offload the spine. I know such traction devices are very popular in India, or commonly used in India. The challenge with them is very little adjustability in terms of parameters that you can do, and the angle of pull and the adjustment of the table. So the table adjustment is extremely critical in getting the right forces, right amount of forces being directed to the right level of spinal segments. That's very important. So what happened in the last few years, and I've been myself watching from the early 90s to the late 90s, there has been a shift that happened to concept called spinal decompression therapy. Now, in United States, chiropractors are playing a large role in spinal care of the patient. That's something that is not so popular in India, but in America and Australia and certain part of the world, chiropractors have been doing. Now, if you look at chiropractors, they are actually supposed to be working on manual techniques. So they use largely the manipulative techniques to manage the patient, the spinal condition of the patient. But you will be surprised that chiropractors, after working all these years, started looking at what physios have been doing, and they're using the mechanical forces, and they started embracing the mechanical forces because their hands were wearing out. They could only do X amount of force in a day, and that too not sufficient enough, unfortunately. So they moved their focus to the mechanical tractions. And this was one of the first generation spinal decompression that was created by Dr. J.B. Saunders. I believe some of you may know Dr. Saunders have written books on low back pain management and has been pioneer into this area of back pain management. So he created this spinal decompression system. It's the first generation. And they had very good outcomes. And the other one going parallel to this was a system called WAXT. Now the WAXT system, if you look at the previous picture as well, look at them. They have been practicing very much a prone lying position for the patient. And I can bet you if I ask you to vote, probably 80% of you will say you never practice prone lying position for traction forces. And that's not uncommon. We're so used to doing the standard way of traction is to put patient in supine and pull it this way. Okay. So then the other major research work was done by other technique called WAXT. Now WAXT was also spearheaded by chiropractic groups who actually looked at the effect of the spine, and they also did high level of studies to actually measure the change in the pressure in the disc while mechanical force are being applied. And they found that a particular way of pulling the spine that follows the pull curves of this pattern, whereby, as you're pulling, you slow down. As you're applying more force to the spine, you slow down. So this slowing or auto slowing pull pattern was pioneer of WAXT, and they did, you can find their clinical papers very easily, and they did a number of papers published as well with extremely good outcome, almost 80% recovery rates or more. Now, if you look at this picture here, this looked like, sci-fi old, Star Trek kind of device. The computers were just evolving those days when actually these were being developed. And the unit looked quite a bit of primitive in a way in terms of designing. And what was important is the outcomes. If the patients were able to get the right outcomes, because now they had the capability to alter the forces applied to the spine to get the desired physiological effects. And that turned the game altogether. And soon we could see a lot more spinal decompression systems being evolved. So this is DRX 9000 system that came into the practices after a while ago. Looks really space age, hi-fi, but honestly speaking, when I've gone through the specification, there's nothing more than, adjustability of mechanical forces. So what you look at a mega design is basically a design, and it can be done from a smaller version design. But I believe that's a marketing game people have played, and it was successful. And later on, some more systems came into the markets. The system like WAXT, which I shared with you, I mean, it costed like $100,000. So any of these systems came in, spinal decompression system, though applying force to the spine, were almost selling at 50,000 USD each system. And why they were able to sell, why clinicians were able to charge to the patient, because they were able to give them the result. And that's very natural. I mean, I can put a patient only first time onto the table, but I can't get them to come back again and again unless I show them improvement. That's very important. And that did happen because the technology, by way of its adaptability, was able to provide more option for the patient's treatment. And then we have this system which we are using in our center in Singapore. It's called DOC, Dock Decompression System. It's quite versatile as it is able to apply the forces and different positioning. Now, when we are applying mechanical forces or decompressive forces, what are we looking at? When we apply mechanical force to the spine, okay, we are looking at stretching effect. Okay, we are looking at mechanical effects, as you can read here. I won't read through in details because I believe I may run out of time. I've got a lot more slides to go. And you're looking at physiological effects. So there are certain mechanical effects, those are taking place, which will translate. These mechanical effects will translate into physiological effects such as nerve root relief, disc retraction, mobilization of joint, and improved circulation. So what is important to understand is factors that do not allow decompression to happen. So why don't we get such great results with standard traction forces? Because we are unable to address certain issues in these devices. So whenever we have back pain, acute pain, so for example, we need to look at two major group of factors. One is intrinsic factor. Second is extrinsic. Intrinsic factors are built within our body. It's in our system. So, for example, if you have a back pain which is severe, your muscle will go into spasm, right? Your muscles will go into spasm because it's a guarding effect. Our body will try to protect any further injuries, and the muscles goes into guarding effect, and that is paraspinal muscle spasm. Now, when you try to stretch these painful muscles, what happens is your stretch receptor response will come in. When the stretch receptor response is triggered, that will not allow the spine or the joint to be separated apart. It won't allow it to pull apart. And our body is maintained or built in a way to keep the joint in positive pressure state. We cannot just fall apart the joints. So that's our natural body's mechanism that will restrict any external mechanical force applied to the spine. Apart from that, then we have extrinsic factor. Extrinsic is outside factor, outside our body. These will be the machine and the tables that you use. So the machines, if they are not able to adjust to the features, it will be very difficult for us to get the right outcome. The tables, their height adjustment, angle to the table, friction level of the table, all are very critical. Okay. Belting system sometimes, although very minor aspect, but very critical. You know, I've seen many times in clinicals, if the belt is not good, the therapist will put the belt, and when the force is applied, the belt slips off. And that's not something that is advisable. So the belting system has to be very secure that once you trigger the force, it does not slip off. So in terms of applying mechanical forces, there are three phases of force. We can see here. First is the progressive phase. Progressive phase is when we are loading the spine from zero force to the set applied force, maybe say 30 kilogram. And then is the treatment phase or traction phase, and then is a regression phase when we are going down the force. So three important aspects here are position of the patient. That's very critical. The amount of force you apply, that will directly have relation to the outcome. And the speed is also very important. How fast do you pull? How quickly do you pull? If you pull the spine, which is in pain, too fast, too quick, it may happen the stretch receptor response will come in and lead into more spasm. So these need to be taken care. So while we are actually loading the spine into the, if we are loading a spine in a way, so if it's a traction force that is applied, it's very important how we pull it. Do we pull it slowly up, or we go into step, step, step? How many steps do we take? There's few questions we have to ask. I'll address this quickly right now. What is important is when you're pulling acute spine, all right, you got to pull it in step. That means you don't go on and stretch the spine all the way, because that could trigger the stretch receptor response. We tend to go pull, hold, relax. Just like with you work with the neuro cases, right? If they have a spasm, you stretch them, but you hold and give them time, and then you stretch again, and then you stretch again, right? A painful spasm spine muscle is also behaving in a similar way. So we cannot continuously pull them with a high speed. We need to break it. And that is important because research has shown it takes about 12 to 15 seconds for muscle spindle to reset to the lengthened position when you stretch them. So we may require about 9 steps, for example, to reach maximum force. If you're giving 30 kilogram, right? So you may give 3.3 kilogram force and then wait for 12 to 15 seconds and then step forward, step forward. When the patient improves their condition, then we can actually reduce these number of steps and make our treatment more aggressive. So for subacute cases, if the patient becomes chronic, then we can use maybe 3 steps or even no steps, because when the patient is is chronic, we want to mobilize more. So then we can take more step and more mobility. That's important. So if we look at hold and rest time, we can actually determine hold and rest time. Classically, what is needed when you are in acute stage, right? You have to go slowly and you have to give longer hold time. When you're getting chronic, you can reduce the hold time, so you can increase the mobility more than anything else. Now, very important is regression. When the force is being released, we must release it in the same number of steps as we progress. So if we look at how to apply force, and this is what we often practice, there are 2 different ways of you can apply force. One is through the rope model, as you see here. The pull is being affected. The other is more sophisticated devices like this provide actual separation at the lumbar level. So the table itself splits and create this effect. I think I'm not able to run the video. Never mind. So the other aspect is speed at which we pull. The speed is also a very important component. As I said, if you pull a painful muscle too fast, too quick, you may increase the spasm or increase the pain as well. Okay, so the speed, remember, is very important. So in a general rule, when the patient is acute, you got to pull or stretch them very slowly. Now, sorry to say, it can only happen if your devices allow you these controls. But if you look at very entry-level traction machines, they may come only with a single force option. They don't allow you to vary the speed control. My golden rule is, if you are acute, you use slow speed. If you are subacute, you use moderate speed, and you are chronic, you use fast speed because you want to mobilize than anything else. So this is how the pull patterns is broken down. If you want to do, say, 45 kilograms, so starting pull from 0 to step up into 3 steps. So very important aspect is, if we look at the Wax-T pull pattern, this was a classical pull pattern. All right. This classical pull pattern has found very effectively into the lumbar disc herniated cases. Now it is not taking in step. Okay. So what it's doing is, it is not breaking into step like this. it is pulling continuously, but it slows down as the force increases. Okay, it's automatically slows down. Why? Because as we load the spine, now when you apply the force, say 20 kilograms, okay, it just gets over the slackened position of the muscles and soft tissues. But going forward, each and every kilogram of force will create response into the muscles. And that's where we need to be slowing down automatically. So rather than breaking down, it does continuously pull, but it automatically slows down as and when while we are pulling. So in summary of these factors is we have to have adjustability, select static versus intermittent, choose number of steps based on the acute, subacute, or chronic, set your hold and rest time, okay, use your appropriate speed levels, and use auto slow pull patterns if available. So we use different position techniques so that we can actually address the mechanical force to the right level. Prone flexion is a very favorable position. That's how you will be putting patients in your manual therapy. That's how you manipulate most of the things. And the gravity assistance is there. In some cases, we even use extension techniques. So you can see here. Okay. So this is the way we can actually adjust you can imagine the effect it creates on the lumbar region. You can really angulate spine in the desired level into complete prone flexion position. And then we can even do this. So we can even go into extension. Now, if you look at some of the McKenzie's techniques, which have favorably used extension technique, it can become virtually so easy for it to be performed. In extreme acute patients, we are able to position patient in this. Those who really are absolutely acute, they're barely able to move. Such positions can also be adapted if you have a full adjustment onto the table. Your angle of pull will affect where or which levels you are applying force to. Okay? And these tables I will quickly run through. I'm running out of time. Can allow you to do different positionings. So what we have also just quickly shared with you, ending here, we actually have done measurements of spinal segment separation, and we looked at using the imaging ultrasound to measure the distance and effect on supine and lumbar position. So we found that you require much less amount of force while you're using prone flexion, especially in the lower lumbar regions. Okay. Then we are also working on to gaining stability. Once you have acute pain stage settled, you need to make sure your core is built properly, is strong enough so you don't have recurrent episodes of back pain. In our practice, we're using imaging ultrasound to actually scan and show the muscles. So you see in this slide here, you see transverse abdominis, internal oblique, and external oblique. It is very, very clear for patient to understand which muscle they are supposed to be working on, and they have to avoid the trigger of other dominant muscles into the process. And this is a quick recording of how the muscle contraction. So this is your transverse abdominis, you can see here, and your internal oblique, and this is your external oblique. So these are the techniques that we are actually utilizing in complete management of patient from acute to chronic stage of development. And we use a pressure biofeedback to monitor the stability of the spine. We have created a complete software that integrate both of them together. And if this kind of technology is not available, then a small little handheld device like this will also be helpful. to just have some monitoring of lumbar stability. So I'm running out of my time, and I know I have to conclude now. So my final message is, winners in whichever field you are, they don't have to do different things. They have to do differently. It's a quote by Shiv Khera, a known author. And you can always reach us as well. And that's my email address. Feel free if any of you want to reach us. And you can also learn more about SCORE's solutions, and happy to visit our centers, Physiotherapy Center. Thank you very much for listening.
Thank you very much, sir. It was indeed a very informative and knowledge-gaining topic, as well as the talk that you gave. Very interesting topic personally, which I felt, because I had heard a lot about this decompression therapy, but then I was not able to actually see what it is. So I had just heard it is in Bangalore and few metros, but today I was able to actually get in depth knowledge about what it is and exactly how it works. Although a lot of questions are there in my mind, which I'll reach you out with through mail, sir.
Yeah, sure.
Sir, a few questions asked by the participants.
Yeah.
So the first question is, what is the common reason for back pain?
Well, honestly, well, I'm not sure we have time enough to do. I mean, a common reason I already have explained. They could be related to the bone, muscle, or the nerve itself. Broadly speaking, that was my very first slide.
Yes, I
probably somebody missed it.
Remember, yeah, probably. The second question: in absence of decompression therapy, can we use manual traction for LVP or disc protrusion? And how can we compare manual traction with the decompression therapy?
You see, the thing is, the problem with manual therapy in axial force application, it is very difficult for anyone to physically apply. To create decompression, you have to cross the force of more than 20 kilogram at least. Okay. So as I said, you will require about 3 millimeter of space creation to create actual decompression effect. And that is very, very challenging for anyone to physically do it, unfortunately.
True, sir. So
for
maybe
cervical,
we are just working on the soft tissue level when we are talking about.
I mean, if it is facet joint and all, that is good. You have to see what, but if your objective is to look at creating decompression on disc.
At the disc. Definitely it is not possible. Yeah. The third question is, can prone traction be given in traditional traction machine?
You could try, but at least if you have high, the height elevation, that will be good. Motorized traction tables at least, but if it is static, it will be a bit challenging. It may not be the most appropriate, but it depends on traction table. Yeah.
True, sir. The next question is traction appropriate for geriatric patients having chronic low back pain?
Yes, sure. Not issues. Just be careful about severe osteoporosis kind of situations.
Yeah. Okay. Next question, sir. Can we give decompression technique even in cervical conditions?
Yes, absolutely.
Okay. And so one more. There are multiple high-level evidences on core muscle strengthening versus
the traction technique
where mainly shows traction is adjunct therapy to exercises therapy.
Yeah.
Your opinion on this?
Well, my opinion is very clear. I think both are working hand in hand, but with different objectives. Though both are complementing, and that is where is the creation of our SCORES program.
Yeah, true. Absolutely, sir. Sir, this ultrasound therapy guided something new for me. How is it exactly done? When you put the patient on the traction?
No. We're not putting on traction actually.
You're using it as a outcome measure, like as in.
We're doing it for core muscle training more than
For training the core muscles. All
yes,
right.
yes. So patient is able to visualize their, transverse abdominis. Typically, what happens when you do, you see, when you do your core technique training, right? You're doing, say, simple tummy tuck, right? That's what you teach patients.
Yeah.
Tummy tuck, right?
True.
Pulling the belly button to the spine.
Spine. Yeah.
Now, when you do that, it's been found if your core muscles are weaker, your other larger abdominal muscle takes over action. Your internal and external act more than your transverse abdominal. Okay. So unless you are able to see it and show it, patient would never understand how to isolate it. And with the beauty of imaging ultrasound, we are able to show them all three layers. If you remember the slide,
yeah, I remember.
You could see the three layers very clearly, and you can see on the screen in action very clearly. Once you do that, what is important? The patient first time understand why they are supposed to do these exercises. Trust me, if I ask them to do 10-second contraction hold with the correct activation, they will be exhausted, literally exhausted. Mm-hmm. And when they feel that, then they realize, oh my God, there's something wrong with me. I can't do it. Such a simple movement, I can't do it. And then they value the importance of exercise. And then that's what we see. We get patients who go through it and they see, wow, they just can't. And then they want to follow it. They want to learn it correctly. And the importance is, if you do repetition by visualizing a couple of times in clinic, say you come 5 to 7 days, or say 10 sessions, the brain memorize the pattern. And soon you can actually do it without visualizing because the brain has memorized the contraction pattern. So it becomes what we call automated response. Yeah. So our objective is conditionally train them visually and then lead them to the automated response.
Yeah. More of a motor relearning.
Motor relearning, absolutely.
Yeah, okay, sir. And sir, any absolute contraindication for this decompression machine?
Well, as I said, any malignancies or severe osteoporosis, if you have the cord sign, then you have to be very careful with these patients.
Okay. And unless a myelopathy or severe neurological.
Yes, absolutely. If you have especially cord
compromise, cord is involved.
Yeah,
all right,
correct.
Sir. Great, sir.
Yeah.
Thank you very much, sir, for your patient response to all the questions.
No, it's my pleasure, and I'm always happy to help anybody, anytime. Please reach us. You have all contacts information.
Definitely, sir.
Good luck. Wish you all the success for this great event. Excellent.
Thank you, sir. Thank you for being on the panel of esteemed speakers, and it was a great pleasure having you.
Thank you very much.
Thank you, sir.